Well, good morning. I have the privilege of introducing session number 2 this morning, and the focus is on ICU updates, and we have two excellent discussions that not only bridge the intersections of anesthesia and critical care medicine, but also public health as well, which I think is a real bonus for an anesthesia conference. Before we start, I want to introduce both of our speakers as well as their topics. And our first speaker is Dr. Aaron Douglas, and there's a lot I could tell you about Dr. Douglas since he's been a dear friend and colleague of mine for almost 15 years. He's a graduate of the Kansas City College of Osteopathic Medicine. He did residency in anesthesia at the Cleveland Clinic, and then he stayed there and he did 2 more fellowships, critical care medicine and in cardiothoracic anesthesia, before he started his career there at the Cleveland Clinic in the Department of Cardiothoracic Anesthesia. Dr. Douglas is board certified in critical care medicine and neurocritical care. And he's also certified by the National Board of Echocardiography in advanced perioperative TEE and in adult echocardiography, which is certainly a real kudos to him. And Dr. Douglas holds a master's degree in medical management, which he got from Carnegie Mellon University in 2018. So it really shouldn't come as any surprise to anyone that last night we honored Dr. Douglas by inducting him into the 2022 fellowship class of the American Osteopathic College of Anesthesiologists, and we're very grateful he's here. Sadly, for me anyway, Dr. Douglas left the clinic about a year ago, and he moved back home to Kansas City, Missouri, and he now works at St. Luke's Health System, where he practices cardiac anesthesia and critical care medicine in their cardiac vascular units and their neuro ICU. Now, I have to tell you, I'm kind of a slacker and I like to get other people to do my work for them. So about a month ago, I emailed Dr. Douglas and I asked him to send me a few bullets for my introduction. And his response was characteristic and terse. And he said, honestly, 2 sentences on my achievements are more than enough. And so I'm looking for them. Where are they? Where are they? Okay, I don't see them. And then he went on to say, I am honored to be a contributing member of the AOCA and our osteopathic community. And I am more proud of our continued osteopathic growth, acceptance, and the excellence of DOs rather than anything I will ever do, which so kudos to him. So, now our second speaker is Dr. Nakul Kumar, who is equally distinctive. He's not a DO, but as you will see, he really should be. Okay, and I have the privilege of working with Dr. Kumar at the Cleveland Clinic. Dr. Kumar did his residency in anesthesiology at Wayne State University, Detroit Medical Center. He then went on to Montefiore Medical Center in New York for his cardiothoracic anesthesia fellowship, and then came to the Cleveland Clinic for his second fellowship in critical care medicine. After this, he joined the ranks of our Anesthesiology Institute as a staff anesthesiologist, and he splits his clinical time 50-50 between the departments of cardiothoracic anesthesia and intensive care. Dr. Kumar's academic interests include the management of ICU delirium, TE in the OR, critical care ultrasound, and ECMO. And I did find an interesting item buried in his CV, and that is Dr. Kumar has a master's in science degree in undersea and hyperbaric medicine. And apparently he did some special training in the Dutch Antilles, and I imagine he probably has some great sea stories he could share with us when he has the time. Dr. Kumar is going to discuss post-ICU syndrome and its anesthetic considerations. So without further ado, I want to please give a warm welcome to Dr. Aaron Douglas, who is going to be discussing the anesthetic considerations with COVID and elective surgery.
Dr. O'Connor, thank you. That was very kind. So again, my name is Aaron Douglas. I'm an anesthesiologist intensivist from Kansas City, and I'm going to talk about long COVID and elective surgery. I don't have any disclosures. I wish I did, because that usually means that you're making money doing something else. Goals here today, I'm going to painfully define long COVID, give you a little bit of background on that. Secondly, most of the bulk of my talk is going to be spent on reviewing the current literature, and I hope to give you somewhat of a framework on how to prepare these patients for surgery. I found this extremely challenging to write. Another AOC member called me a few months ago and said, you know, Aaron, can you please give a talk on COVID and surgery? And my heart just sank. I thought, how can I get out of giving this talk? Because I knew a little bit of the literature, there's a lot of wiggle room in it, and I thought this is going to be impossible to give people really firm guidance on what to do. And my intuitions were correct. So I think the challenge here is to give you really up-to-date advice. There's a new paper in COVID coming out, it seems like almost monthly. Secondly, I certainly don't want to read you a list of guidelines that would, is audience torture. And finally, as I mentioned before, giving meaningful advice and real information on what to do, I think is going to be a challenge. So my other initial thoughts for this topic when I sat down, before I had pulled a single paper or made a single slide, is I thought to myself, I do so much critical care, can I extrapolate anything from our COPD patients or ARDS patients? And the second thing I thought is, COVID, without a doubt, is a whole body disease. We tend to overly focus on the lungs, but how much do the other organ systems really matter? Multiple names for long COVID that you probably know. The one most commonly used in the literature now is post-COVID conditions. I don't think that has quite a nice ring to it, but that's the one that I'm seeing the most. Also post-acute COVID-19, chronic COVID, and then long haulers. So they always say if you have to apologize for your slide, you shouldn't use it. I'm going to apologize and use it anyway, because I think it's important that you see what the CDC says the definition of long COVID is. So the CDC says we use post-COVID conditions as an umbrella term for the wide range of health consequences that are present 4 or more weeks after infection with SARS-CoV-2. The time frame of 4 or more weeks provides a rough approximation of effects that occur beyond the acute period, but the time frame might change as we learn more. It's certainly not a firm definition. I applaud them for at least being flexible enough to realize that the wording may change. World Health Organization also has a definition. It's somewhat longer, but equally as soft. The WHO says post-COVID-19 condition occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained for an alternative diagnosis. So just to compare apples to apples, just the time frame. CDC says greater than 4 weeks after infection. World Health Organization says greater than 3 months. So there's quite a discrepancy there. Who's most likely to get long COVID? I think you know most of these. They're the patients that were admitted to the hospital. They're the patients that spent a long time in the ICU. They were the ones intubated on ECMO, had underlying health conditions, were typically unvaccinated, and had a history of multisystem inflammatory syndrome. I think you know most of these too, the symptoms, but I made these 2 lists on purpose. If you look at this list on the on the left, headache, myalgia, sleep disturbance, hair loss. If you're an anesthesiologist and you go to the preoperative holding bay and you're prepping a patient and they're complaining of these, I would say you're probably not overly concerned. As long as the patient doesn't appear toxic, you're probably not super concerned that the patient has organ failure or organ dysfunction. If you look at the list on the right, other common symptoms from long COVID, chest pain, tightness, palpitations, tachycardia, those are certainly the ones that are more concerning. Those are the ones that give us pause, that make us wonder, is the patient truly optimized for surgery or not? So here's some studies to know. This font is small on purpose. It's only a bibliography for later if you're reading these slides at the airport and want to pull some of these papers. Here they are. But I'm going to go through several, about 5 in all. The first paper that I think you should know about is this Huang et al. From Lancet in 2021. It took place at the Jintang Hospital in Wuhan, China. It was a questionnaire-based study. This is what they did. They took 1,700 patients that had had COVID, that were hospitalized, that were discharged. They brought them all back into the hospital and gave them a very extensive questionnaire. Based on their responses, they were stratified into kind of lower risk patients that had few symptoms all the way up to patients that were still pretty sick from COVID. The pretty sick ones, they did a physical exam on, PFTs, 6-minute walk test, labs, and chest CTs. The results were interesting. They found that 76% of patients that required hospitalization for COVID were still experiencing symptoms more than 6 months after hospital discharge. The vast majority of them complained of continued fatigue or muscle weakness, but interestingly, about 35% of them still had a low GFR. I think the study overall is a fabulous explanation of how many people still have continued symptoms, but I do have a consideration for you to think about, and that is long COVID symptoms are nonspecific. So just on PubMed, I pulled a few studies about the general incidence of fatigue. You know, the fatigue in the general population is estimated to be 7 to 45%. These are patients without COVID. Fatigue in U.S. healthcare workers, another study I saw, 38%. I bet I could poll the audience today, and at least a third of you would say that you had fatigue. Musculoskeletal pain also is not very specific. Another study I think to be well aware of, Anesthesia 2021. This article is titled Timing of Surgery Following SARS-CoV-2 Infection, an International Prospective Cohort Study. This was put on by the Global Surgical Collaborative. The Global Surgical Collaborative is a hub and spoke model of about 80 hospitals nationwide that pool their resources for research purposes. And this was their question. They wanted to know, how long after being diagnosed with COVID should you wait before you have surgery? Now, this study is big. It's all the things that you want to see in a study. It's multi-center, it's international, it's 140,000 patients across 116 countries. They looked at patients having elective or emergency surgery during the month of October 2020. I liked it that they defined what is a surgery. Surgery was defined as occurring in an operating theater with a surgeon. I think that's a salient point because I don't know about you, but I get asked all the time to sedate a patient for maybe a bedside EGD or a TEE on a patient with COVID. Those patients were not included. So here's what they found. I know you can't see all the individual bullet points on here. I'm going to blow this up over the next 4 slides here in a minute. But they looked at mortality in 4 subgroups. Patients that had minor surgery, patients that had elective surgery, patients that had major surgery, and patients that had emergency surgery. So this is 4 individual forest plots of mortality. The thing that I want you to take away from this slide is the mortality curves, no matter what type of surgery you had, was all roughly the same. I want to present this data a little bit differently. So here's a slide for the mortality for patients that had minor surgery in the month of October 2020. If you look all the way on the left, this is the control group. These are patients that didn't have COVID, that underwent minor surgery, again in October 2020. They had an average mortality of 0.8. The first yellow graph on there is patients that got COVID that required minor surgery 2 weeks after their diagnosis. Their mortality is more than tripled, and that risk stays elevated until about 7 weeks. So again, this was for minor surgery. What about for patients that needed elective surgery? So again, all the way on the left side of the screen, these are patients that don't have COVID, that got elective surgery as the control group. Their average mortality, 0.62%. Patients get COVID, they need elective surgery, 0 to 2 weeks later, their mortality increases 3-fold. And that risk of mortality still stays elevated for about 7 weeks. What about for major surgery? It tells a very similar story. Baseline control group mortality on the left, patients get COVID, mortality goes up, stays elevated 3-fold for at least 7 weeks. Emergency surgery, exact same thing. No COVID, mortality is 3.56%, patients get COVID, and the longer you wait, the better. So there is a problem with the study. I kept saying October 2020, and there's a reason for that. So if you think about what was occurring in October 2020, that was pre-vaccination. So none of these patients had been vaccinated for COVID. Also, the variant was alpha and beta. We're on to Omicron now. How does that change things? We're not really sure. So what advice is out there on preparing these patients for surgery? Paper number 3, Anesthesia in a Post-COVID Syndrome, Perioperative Considerations for Patients with SARS-CoV-2 Infection. And it's an editorial on that Huang paper. The Huang paper was the questionnaire patient where patients were still suffering from a lot of COVID symptoms more than 6 months after hospital discharge. And here's what this paper says. I know you can't read all the fine bullet points on here, but I just want to pick out a few of them. It's broken down their advice is broken down by symptoms, by systems. So for neurologic symptoms, for example, peripheral neuropathy, the authors are recommending judicial use of neuromuscular blockade. They recommend quantitative reversal of neuromuscular blockade. They recommend a neurology consult. Okay, what about for cardiovascular symptoms? Perhaps the patient still has palpitations or chest pain. They recommend a perioperative EKG. they recommend a transthoracic echo or consulting cardiology. As my 5-year-old is starting to say, "Duh, Dad," I think I applaud the authors for trying, but that advice is pretty general and something that we do for most patients that we're working up for surgery, regardless if they have COVID or not. I pulled several other papers that were all very similar, and here's some verbatim comments from the advice out there right now. Remain vigilant. It's imperative to do a thorough H&P on these patients with long COVID. Document pre-existing symptoms. Depending on the severity, get PFTs. Minimize neuromuscular blockade. Shared decision-making, and be prepared for additional postoperative care. So, certainly not very specific guidance on what to do for patients with long COVID. You might be thinking, where is the ASA in all of this? They do have a paper on it. It's less than 3 pages long, and it's titled Joint Statement on Elective Surgery and Procedures for Anesthesia in Patients After COVID. And I'm not going to read all these to you, but I'm just going to pull out a couple salient facts of what the ASA says to do. They say elective surgery should be delayed for 7 weeks after SARS-CoV-2 infection in unvaccinated patients. Okay, that makes sense. We looked at that paper. We now know why. They also say there's insufficient evidence to make recommendations on those who become infected after COVID vaccination. They also say any delay in surgery needs to be weighed against time-specific needs of individual patients. So they give a couple, I think, salient points, but really, again, it's pretty general guidance on what to do. So is there anybody out there that will offer more specific recommendations on what to do? And that is an emphatic sort of. Remember this paper, this interval between surgery, this whole, hey, let's wait 7 weeks, mortality's less? There is a follow-up paper to it, and this is it. And it is the timing of elective surgery and risk assessment after SARS-CoV-2 infection and update. And it is partially sponsored by the Royal College of Anesthetists. So based on the information from this paper and some of what I just said before, I'm going to try to talk to you about what I think is a rational framework on how to prepare these patients. And it's really based on 3 things. Number 1 is surgical timing. We've already talked extensively about that. The second one is risk assessment. And the third thing is risk mitigation. That paper that I just showed you from the Royal College of Anesthetists, 90% of the information that I'm going to say is taken from that paper. So I've come up with 10 axioms or 10 truths that I think you should think about when you prepare these patients. Number 1, wait 10 days for elective surgery. You might be saying, 10 days, where's this coming from? We've been talking about 7 weeks the whole time. Yes, if you can, wait 7 weeks, but if at all possible, wait a minimum of 10 days. And the reason for that is the patient is predominantly still infectious, right? There's a risk to the healthcare team that they may get COVID, and there's a risk to other patients in the hospital that may get COVID. Number 2, there's really no evidence on surgical outcomes after SARS-CoV-2 vaccination. All those studies that I talked to you about before that showed elevated mortality were in unvaccinated patients. We really don't know what the mortality is going to be for patients that have been vaccinated. That study is underway right now, but the results aren't out yet. Third thing, the view that persons with the new variants, aka Omicron, or patients that are asymptomatic with COVID that present for surgery, the idea that they would be at lower risk right now is just not justified by the literature. We have to believe that all these patients have elevated risk. The fourth thing, patients should receive 3 doses of vaccination. Again, you might be thinking, duh, and how does this come into play? So think about this fictitious patient. Perhaps it's somebody that comes in, they need an advanced big spinal fusion. It's not an emergency surgery. They've got some health problems. You're prepping them for surgery. They're unvaccinated. That is the ideal time to try to talk that patient into getting vaccinated and coordinate with the surgical team to say, you know what, this case isn't an emergency. I really think that we should wait a few months and try to get this patient vaccinated. Axiom number 5. Patients should notify the surgical team if they test positive within 7 weeks of surgery. Again, we have to assume that there is elevated risk if you get COVID and need surgery within 7 weeks. If this is the case, then joint decision-making rules apply. Really, does the case have to be done or not is what it comes down to. Number 6, patients that have persistent COVID symptoms, very similar to the Huang patient, are likely to be at increased mortality even beyond 7 weeks. I want to say that again. So if you have a patient that presents for surgery and they had COVID 5 months ago and they're still having symptoms, I'd recommending wait longer if you can. Number 7, address modifiable risk factors such as preoperative exercise, nutrition, smoking cessation. Again, I know that's not earth-shattering or new advice, but it's still something that we should strive to do. Number 8, use the SORT2 calculator or the NSQIP to share with the patient and the team the patient's baseline risk. So these are 2 new words, SORT2 and NSQIP, and I just want to talk about what that is. All right. You don't need to be able to see all the small detail on these slides, but on the left side is the NSQIP calculator, and it's from the American College of Surgeons. It has things such as age, CPT code of the proposed procedure, hypertension, BMI, ASA class, and the NSQIP calculator helps predict the patient's risk of any 20 complications, including DVT, death, PE, MI, etc. The other calculator that you can use to inform the patient and the surgical team of baseline risk, and the one that the Royal College of Anesthetists is really pushing, is the SORT2 calculator. And that's the surgical outcomes risk tool. And it's very similar to the NSQIP calculator, although there's way fewer variables. I think it's easier to use. Axiom number 9, target your workup based on how the patient looks. I think when these patients present to your preoperative clinic or your preoperative holding bay, it's reasonable to obtain a baseline CBC, CMP, and EKG. You could possibly consider getting an echo or a chest x-ray, a D-dimer, or pro-BNP, only if you think it's going to change your management and only if the patient doesn't appear non-optimized to you. And finally, I think it's reasonable to consider getting a consultation with other experts if you think that it's going to change your management. And my final axiom, which is a little bit more specific, is the Royal College of Anesthetists advise avoid general anesthesia if possible, as there is some evidence of higher rates of respiratory dysfunction. And that is very similar to how we would treat a COPD patient. So two summary slides just to cover everything that I've talked about. Number 1, if you take anything away from this, take away that there is an increase in mortality for elective surgery for patients that have a COVID diagnosis less than 7 weeks before their proposed surgery. Patients with persistent symptoms have increased mortality probably after the 7 weeks as well. Finally, there's no data to suggest that if you vaccinate a patient or if the patient has Omicron, which is supposedly less severe, that they're going to have less mortality. That study is going to come out soon. I predict that we will see lower mortality, but again, it's not out yet. Final slide. Consider using this SORT2 calculator and the NSQIP calculator. It's really not as cumbersome as it looks, and you may find use for it in your preoperative clinic. I think it's a good way to really quantify risk, not only for the anesthesia team, but to show the surgeon and to talk to the patient. For patients with persistent symptoms in terms of the workup, don't forget, you're the perioperative expert. I don't think that we're gonna see an overly robust guideline or algorithm saying that you have to get an EKG on every patient, you have to get a chest x-ray on every patient. I think you need to use your physician skills to really determine what tests need to be done, what tests are going to help you, and what tests you should not do. And finally, be honest with patients. They deserve our transparency. This is the real meaning of shared decision making. If a patient cannot walk 2 holes of golf, them undergoing a total colectomy with chronic COVID is unlikely to be a walk in the park. And with that, I want to thank you, and Dr. O'Connor would be happy to answer any of your questions. All right.
A little gotcha moment there. I like that recommendation, be vigilant. I'm going to try to remember that one. Okay, I want to give a warm welcome to Dr. Kumar, who's going to talk about post-intensive care syndrome and its anesthetic considerations. Thank you.
Thank you, Dr. O'Connor. It's really a pleasure and honor to be here. Thank you for the invitation. I'm sorry, could I get a second?
So, big ring back before?
I just wanted to get my presenter view.
Oh, yes, sorry. I'll take care of it back there.
Great, thank you. All right, so I'll be talking about post-ICU syndrome. This is a little-known entity that has been gaining a lot of traction in the past few years, especially since we're seeing a lot more of our patients that are improving from their ICU stay. They're actually surviving, they're leaving the ICU, and we're going to be able to see them in our post-operative assessments. We're going to see them when they come back for surgery in the future. All right. So I'd like to start off with sharing a powerful quote from an ARDS survivor, Susan East, who is now also a very staunch patient advocate for this. It's one person can still function and work while another patient who was only hospitalized for 3 days in the intensive care unit will not leave her home. Some people's entire life may be destroyed by fear. Based upon my own and others' experiences, I advocate for early physical therapy and humanizing the ICU as much as possible. So the goals for the presentation today will be to define what post-ICU syndrome really is, or PICS to keep it easy. Understand its incidence in our ICU population, discuss some of its impacts, identify risk factors for its development, and talk about some of the strategies for prevention and current treatments available, and how anesthesia can play a role in that as well. So, as we know, ICU survivorship is increasing. There are more than 5 million adult patients who are admitted to the US intensive care units each year. Of these patients, a much greater number are surviving their ICU experience compared to decades prior. As mortality improves, there is increased interest in research into what is happening to these patients once they leave the hospital and what's happening to them in their lives thereafter. And based on this, the term post-ICU syndrome was developed in 2010. So this is a graph from a study by Zimmerman and colleagues that were looking at over 400,000 ICU admissions since 1988, which shows a relative decrease in mortality by approximately 35%. Now, this is in the setting of an increasing age and increasing mean acuity score for these patients being admitted to the ICUs as well. So what does PICS consist of? By definition, it includes a new or worsening impairment following critical illness in 3 major domains: the physical domain, mental domain, and cognitive domain. These symptoms may resolve shortly after discharge, or they can last for months to years for some of these patients. Nearly 50% of patients who survive the ICU experience will have some form of impairment on discharge. And this may seem reasonable that they're going to recover from this, but when we look at the longer term data, we see that only 45% of these ICU survivors actually are PICS-free at 12 months when they came in with no impairments at all, compared to 55% that will retain an impairment in at least one category beyond 1 year. In addition to this, post-ICU syndrome can also affect family members, and that's designated as a term as PICS-F for family. This is a graphic representation of the different components of PICS. Importantly, the components don't always occur separately, and there is significant overlap between them. A small subset of patients can get a lot of comorbidity from having all three domains impact them in their daily life. Associated with that are the mental health issues that affect family members during their ICU stay and thereafter. When we further break down these components of PICS, we see a variety of different ways in which clinical phenotypes for PICS can manifest in different individuals. Notably, when we look at the similarities in mental health for family members and the patients, they can resemble them very closely with anxiety, acute stress disorder, post-traumatic stress disorder, depression, and then the potential added pain for family members of losing their loved one as well. Of the three components of post-ICU syndrome, its physical manifestations are often the most visible. New physical impairments affect ICU survivors in the form of a syndrome labeled ICU-acquired weakness, and this affects up to 80% of patients that have been on a ventilator for more than 4 days. Impaired mobility often leads to greater degrees of muscle loss and difficulties in participating in physical therapy. Moderate to severe chronic pain, as we've just heard a wonderful talk on opioid use disorder, in this wide range of population can be noted anywhere between 15 to 70% of ICU survivors based on the type of population that you're dealing with. Pre-existing chronic pain conditions can further exacerbate that risk for these patients as well. Dysphagia, another extremely common finding in the ICU setting in acutely ill patients, contribute to both malnutrition and the risk of aspiration, which, when you follow these patients after ICU discharge, increases their risk for hospitalization and ICU readmission as well. Respiratory weakness is found in more than 50% of patients who survive ARDS and prolonged mechanical ventilation. Unfortunately, this is also part of a greater cycle of critical illness where ICU-acquired weakness sets in after prolonged ventilation that contributes to further prolonged ventilation and increasing ICU hospital length of stay and long-term mortality. Looking a bit closer at the physical portion of this, we can divide ICU-acquired weakness into 4 distinct subgroups. One of them being muscle deconditioning, the others critical illness myopathy, critical illness polyneuropathy, and a mixture of those two. The incidence of this is about 40% in critically ill adult patients. Most of these subsets are going to be of critical illness myopathy, with a much smaller set of patients having polyneuropathy with nerve conduction. But outside of muscle deconditioning and atrophy, which results in normal diagnostic studies, CIM and CIP both have measurable disturbances in muscle excitation, nerve conduction, or both, sometimes resulting in quadriparesis and very inappropriate sensations, just such as allodynia. Survivors of ARDS and other critical illness often have muscle wasting of over 15% of their body weight during ICU admission. The immobility and bed rest are both modifiable risk factors during critical illness that can result in substantial disuse atrophy and accelerated muscle breakdown. In a study by Fan and colleagues, they saw that the duration of bed rest was the single greatest risk factor in developing muscle weakness throughout the entire discharge follow-up. And each additional day that a patient was on bed rest had an 11% decrease in muscle strength at 2 years post-op. Mental dysfunction can also manifest in very different ways. One of the main ones are depression, anxiety, and PTSD, which on its own afflicts anywhere between 10 to 50% of patients after ICU discharge. Patient experiences that can lead to PTSD also vary significantly, some of them stemming from auditory or visual hallucinations in their ICU surroundings and from ICU-acquired delirium. For example, a patient who was sedated while on mechanical ventilation with soft restraints to prevent injury to them then thinks that they are being incarcerated, they're being held against their will, they're being strapped onto an electric chair, and all of these thoughts contribute to them developing these symptoms postoperatively. It can significantly worsen their life. These symptoms also can lead to a decrease in patients' job performance on returning to the workplace and could potentially lead to loss of employment altogether. Mental impairment also follows a two-hit pattern in which there are often pre-existing factors that patient come in with, and then you put them into this very distressing ICU environment, and then the outcome is related to the mixture of those two things. Cognitive impairment is also probably the most difficult component of PICS for families and patients because it's not very easy to see from the get-go. There are a large host of manifestations in cognition that can be seen, but the most common include dementia that's worsening, impaired problem-solving skills, planning memory, and these can be seen in anywhere between 30 to 80% of critical illness survivors. A large study that was done in looking at patients leaving medical and surgical ICUs from respiratory failure and shock was the brain ICU study done in 2013, and it specifically looked at cognitive impairments for these patients leaving the ICU. What they found was that longer durations of delirium were independently associated with the worst global cognition scores, and they used a specific test called the repeatable battery for the assessment of neuropsychological status, or the RBANS test to keep it easy. And the striking findings from this were that the patients with 5 days of delirium or more had significantly lower scores than patients who did not have delirium. And most alarming was that 34% of all of these patients had global cognition scores that resembled moderate traumatic brain injury, and 24% of all of these patients had scores resembling mild Alzheimer's disease. Of course, we have to talk about COVID-19 survivors as well, and we just had a wonderful talk on long COVID symptoms in patients who are surviving their ICU stay. Unfortunately, COVID-19 has not proven to be any different for our ICU patients. Looking at this Dutch COVID-19 study following patients who survived the ICU, found a similar story where nearly 75% of patients on follow-up reported some kind of physical impairment, 26% reporting some kind of mental impairment, and 16% who reported cognitive impairments at 1 year follow-up. Most significant of these symptoms were by 10% of patients who had an impairment in all three domains. Bridging the gap between what PICS might be and what long COVID symptoms might be, we see a similarity in these presenting symptoms: shortness of breath, chronic pain, cognitive decline, depression, fatigue, sleep disturbances. So all of these patients have a lot of similarities with patients who did not have COVID and also survived the ICU. And the impact on our patients is understated here, because when you have an impairment and you try to live your life when you'd never had one before, it's something that is very personal and individually distressing. And the emotional distress can manifest for patients in very different ways. One of them can be avoidance of health care altogether after surviving this, which then we describe them as being non-compliant, but in reality is the fear that grips them by not wanting to go back to the hospital. Of course, this worsens their outcomes because often it leads to readmissions from worsening chronic illness that goes into an acute illness. Physical impacts from the inability to perform activities of daily living means patients have to rely on home aid, on family support to perform basic tasks, contributing to the hardships of both parties. Financially, this is the hardest part for patients, is because they have to face larger hospital bills because of their long hospitalization. And at the same time, when they're suffering from PICS, they encounter difficulties in their job performance, loss of employment completely after returning home, and roughly half of patients who recover from ERDS do not return to work 1 year after discharge, and some of them never return to work at all. This has a profound effect on family members. It has a profound effect on the society, because these patients are reliant on Medicaid, Medicare for their ongoing care, and family members that used to rely on these patients for income, for supporting their family, no longer have them to be able to rely upon. And if the most significant symptoms do not improve, a lot of patients can be left with permanent disability. So what are some of these risk factors that we can identify in patients? It's multifactorial. There are a lot of different things that go into an ICU patient being an ICU patient, but I've tried to highlight some of the important ones. A pre-existing mental or physical condition, of course, it's going to exacerbate things. Pretty easy to see. If you came in with COPD, severe heart failure, you're likely not going to leave any better than that. But worse is also the type of critical illness that they come in with, which is it causes a prolonged catabolic state and the bed rest that induces stress and critical illness and can significantly contribute to the critical illness myopathy. The type of critical illness is also important because shock and ARDS states have been strongly associated with these catabolic states. Prolonged mechanical ventilation, and specifically ranging 4 to 7 days or greater, significantly contribute to ICU-acquired weakness as well. Mechanical ventilation has also been associated with hippocampal apoptosis, leading to memory and cognitive impairments. Hypoxemia and hypoglycemia seem pretty straightforward. You always want to avoid those, especially in anesthesia. This is what we do. But the number of times patients have this during their entire stay, the length of time they have hypoxemia and hypoglycemia also contributes to the higher risk of developing PICS from the brain injury, but also from contributing to ICU delirium, which, as we discussed earlier, is an important independent risk factor in the development of PICS. And specifically looking at sedation, there's always been concern in the ICU that, oh, well, the patient's going to remember what's happening on mechanical ventilation, and that's going to be very traumatizing to them. But that's not shown to be the case at all. In fact, there's a potential benefit to lighter sedated patients that can remember the hospitalization, that can participate in physical therapy, and it's shown to decrease the risk of PTSD in these patients. Because delirium plays such a big role in the risk of developing PICS, we have to talk about post-operative delirium in this case as well. Some of the risk factors are, of course, major surgery, large abdominal pelvic surgeries, complex surgeries, requiring longer ICU admissions are independently associated with the higher risk of delirium. But also depth of anesthesia. Now, there isn't a ton of literature out there, but we can see that the patients under a profound, deep anesthetic with EEG waveform monitoring have a higher risk of developing delirium. And when you combine that with the type of surgery, the complexity of surgery that they can have, this can be another confounding factor. Higher postoperative pain scores. Patients who have pain that is tough to deal with in the ICUs are also at a higher risk of developing postoperative delirium. And even patients who are not in ICUs, especially elderly patients undergoing hip arthroplasties, have a higher risk of delirium when their pain is not adequately controlled. Blood transfusions, both intraoperative and postoperative, have been shown to have a higher association with delirium. Specifically, the larger the volume of transfusion, the higher the risk of delirium. Profound hypotension and shock, of course, makes sense, is a big factor to this, but the duration of this also matters. And then acute kidney injury has been shown to be an independent risk factor for developing postoperative delirium. And then neuromuscular blockade. This point, we use neuromuscular blockade so routinely in our practice. One of the considerations that we usually forget in the ICU setting from an anesthesia side of things is when you're giving sedation for surgeries or procedures that may not need neuromuscular blockade, it's always better to avoid it because the more and more you give, the harder it is going to be for the patient to recover. And most of the time, we're not giving these patients reversal in the ICU as well because of the side effects from the neostigmine and the glycopyrrolate that these patients can experience. One of the examples I give with this is bronchoscopies. Some patients may need no bronchoscopies at all, or some patients with thoracic surgeries may need daily or twice a day bronchoscopies to clear some of the secretions or especially bleeding if they had bleeding in their airway. Every single time they get paralysis for them, they increase their risk for neuromuscular weakness, ICU delirium, and therefore PICS. So, prevention and treatment strategies. One of the biggest ones comes from our normal ICU management, which is the ABCDEF bundle, widely known as an evidence-based guide to optimizing ICU recovery and liberation. A little bit of modification to this, and this is what is also helpful in helping to decrease the risk of PICS in these patients as well. One of the additions that we can add here is FG and H, which is really focused on family empowerment by improving communication and education for family members to help in the prevention and treatment of PICS as well. One of the key points I'd like to highlight here is also C, with just coordination of care and communication, that also fit into the same category as choice of sedation and analgesia. Some patients do better with much lower levels of sedation, and some people need higher sedation so that they can be managed appropriately in the ICU. But that distinction is very important to make in an ICU setting, because you don't know who's going to need what, and an individualized attention to treating them with the right kind of sedation is really going to be helpful for them. Another concept that's shown to be helpful in the management of PICS is the creation of an ICU diary. They can be written by family members, nurses, or physicians that take care of these patients, and they can include the description of procedures, invasive lines that have been performed for these patients as well. And the main goal of this is to fill in any of the memory gaps that the patient is likely going to experience during their ICU stay. Offer them encouragement during this period of time, which can be done not only by the family members but also from the caregivers. And it helps it is shown to be helpful in decreasing anxiety, depression, and development of PTSD post-ICU discharge. Photographs can also be helpful in filling gaps for a lot of patients, can really emphasize the type of critical illness that they have. And thankfully, there is growing data on the usefulness of this strategy in ICU care, but a lot of it is limited to the United Kingdom. We just don't use it very often here, and there are no standard guidelines for the best approach to facilitate this. Looking into ICU diary literature, there was a meta-analysis recently done that looked at 6 different randomized controlled trials on this ICU diary and its usefulness in the ICU. The biggest takeaways from this are that this showed a lower risk for depression for patients. It also showed a better healthcare quality of life when they could review these diaries. But most importantly, the findings were that the writing and reading of the diaries, the family members could document their presence at the patient's bedside, express their love and affection, confide their intimate feelings, and struggle to maintain hope. Also, reading the diaries made the relatives aware that the staff actually saw the patients as living human beings, and that the time devoted by healthcare providers to the diary was seen by families as a sign of consideration, emotional involvement, and empathy. And the reason I highlight that point is because a lot of the issues with starting this program in the United States has been legal. What are the patient's family is going to say if they're writing things down that they don't understand, or what if we write something down that we don't all agree with? But when we look at it as a whole, we write things in patient charts all the time. Writing them in the diaries is no different. At the same time, when you see something written by a family member in an ICU diary that you may say, oh, they don't actually understand what's happening. Let me talk to them. Let me clear the air. Let me show them or explain to them what it actually means, what they have been, had a misconception on potentially. And it's actually shown in some small data to reduce the incidence of patients and family members having legal troubles, because you can explain to them what's actually happening in a longer term way. We all know the importance of rehab and nutrition on recovery after ICU and critical illness, but it can't be understated in the ICU care. Malnutrition and the inactivity accelerates ICU-acquired weakness and subsequent PICS that can develop from that, and especially skeletal muscle and volume loss. This, of course, leads to an increased risk of infection, increased risk for ICU critical illness requirements, and then the whole cycle starts over again. So in this place, nutrition and early rehabilitation are going to make a huge difference in the patient's recovery. Outside of that, cognitive rehabilitation has also been shown to be very helpful, very similar to patients who had strokes. And having them go through the same program shows a decreased incidence of PICS in those patients as well. And then post-ICU clinics. This becomes a more controversial topic, especially here, because it's a non-standard approach, but it is quietly gaining some more ground in patients who leave the ICU. And one of the goals really is to facilitate the transition from the critical care atmosphere back to the primary care providers to address some of the underlying issues and potentially some of the residual issues that these patients are going to have afterwards. And another is to improve the understanding of the patient's actual ICU stay and what happened there, and address any misconceptions and gaps in times that they may have. In addition, the patients have a place to follow up on existing symptoms of PICS and diagnosing any newly developed ones so that they can receive targeted therapy towards their impairment. In 2015, Jensen and colleagues undertook a review on this as well, looking at the effects of ICU follow-up on patient-centered outcomes. And they found that post-ICU clinics did not really help the way that they thought they would. It hadn't had any effect on the quality of life, anxiety, depression, but they did show there was a significant reduction in the risk of new onset PTSD and PTSD symptoms in 3 to 6 months after follow-up, probably due to individualized interventions on these patients and reframing their ICU experience and diagnosing these new symptoms earlier. So what are some of the future directions? When it comes to anesthesiology and our involvement in patients developing PICS, really there is very little data on what we can really do for prevention and treatment. But one of the main things that we have some data on is postoperative delirium and some of the intraoperative factors that we can modify for these patients. Of course, more studies need to be done on this so that we can really elucidate what in the intraoperative period may be in effect. Implementation challenges. This is the greatest concern, mostly because the barriers are that there are non-standard practices like the ICU diary or post-ICU clinics, and all of these usually take funding, time, and space to accomplish, and these are very hot commodities in intensive care practice, especially with COVID-19 in the last few years. We also don't really understand the implications of what the reported qualitative improvements on a patient and their life are, and their family's outlook on life in comparison to what we can actually measure. Sometimes the qualitative effects have the most profound impact on our patients. And finally, if we improve our ability to identify most appropriate patients who would benefit from this type of therapy and give them a humanized approach in the ICU, we have a chance to improve the quality of life for the growing number of ICU survivors that are coming out into the world today. Thank you.
So now, if Dr. Douglas, if you would come up and have a seat between the two ferns here, because I know you love questions. So this brings us to the question and answer portion of this critical care section. And again, I want to thank my two colleagues for 2 excellent talks. And I want to invite members of our audience now to approach the floor microphones if you have any questions. And I guess while they're doing that, go ahead. Yeah, appreciate it. Yep.
Hi, Suzanne Huffnagel from Jefferson Hospital in Philadelphia. Comment and a question for Dr. Kumar. You said that lighter sedated patients sometimes have less PTSD. Do you have any insight on that? Like, do patients actually say things when they get extubated about how they tolerated things like that?
Yes. It's hard to quantify because every patient's individual experience is going to be different. Mm-hmm. But part of the issue that comes into patients and their sedation levels is we oftentimes don't give them the opportunity to be awake, to participate in their care, to ask questions. One of the biggest things are patients writing down what they feel, what they think, so that they can communicate with us while they're on the ventilator. And as long as they don't have significant pain or discomfort with that endotracheal tube, a lot of patients tolerate this fairly well. And lighter sedation, as we've seen in some literature, shows that there is a better outcome when it comes to PTSD and depression, just because they can remember what's happening to them. And
I mean, I can't imagine laying there with the tube in, being not real sedated and how I would tolerate that. One of my biggest fears too is, the trauma patient that comes into the trauma bay, and what do? We rip all their clothes off. We look them head to toe. We don't tell them what's going on. You shove a tube in. I can see how this could be so awful for patients. I'm glad to see that there's some thought about helping that. My other question is that ICU diary considered a legal document, like a progress note is?
That's an excellent question. Lawyers will say that it is, that they can use it in that way. Now, like with any of our documentation, everything is legal. Everything that we do is considered a legal thing, and that can be used in discovery, that can be used in a litigation potentially. And an ICU diary doesn't create any differences from when you're writing in a patient's chart. The only caveat to this is that if you're not reviewing the diary, if you're not going through it with the patients and their families, that's where you may have trouble with it. And so it really depends on the clinicians and the nurses and the staff at the bedside to make sure that if you're implementing something like an ICU diary, review it with them, sit down with them, have frequent family discussions with them so that we don't have any misconceptions. There's no legal tender that can be sitting there that potentially may create a conflict of interest.
And that's too bad, because I think that somebody writing down their experiences can help everybody.
Absolutely.
But, like you said, you have to worry about the legal ramifications.
Absolutely.
Thank you very much for a great talk.
Thank you.
I will tell you, Dr. Kumar, I have one very vivid experience with an ICU diary. Actually, it took place in July at a lawsuit involving me, a lady who developed foot drop, and her husband kept a very detailed diary, and then he retyped it up, and embellished it as he did it. So, fortunately, the case was settled. Anyway, that's my experience with an ICU diary. So I could see it would probably be more useful in Great Britain, where it's a less litigious society as opposed to here. Yeah. I want to ask you, you took that one comment, that quote you had, 3 days, the very moving quote at the beginning, PICS can develop within 3 days or longer. What is the typical length of time that we see the development of PICS in terms of ICU stays?
Usually there's a lot of factors. Yeah, it's a great question because it's hard to quantify an individual's experience in their ICU stay. The data, when you separate those who had some kind of a complication or critical illness from those who were electively hospitalized in the ICU, there is a difference. Elective cardiac surgical patients, for example, have a much lower incidence of PICS and a development of post-traumatic stress disorder compared to patients who are had a complicated surgery and were admitted, or had ARDS and were admitted from an infection. So there are some differences to length of stay based on what type of disease process the patient presented. But we do know the longer that the patients are intubated and the longer they're on sedation, the worse and the higher the risk gets for patients. So that's why as soon as they start developing this ICU-acquired weakness, their incidence of PICS just skyrockets.
I noticed that you didn't have any cost data in terms of what PICS costs in terms of our healthcare system, but I would suspect it's enormous. Is that information out there, or is it not available?
It's out there, but it's mixed into hospitalizations in general. So when we look at PICS as an entity by itself, it's hard to sparse out what is the just chronic illness that continues forward for patients after hospital discharge, and what is PICS-related dysfunction and the cost of care for these patients afterwards. Mm-hmm. But as I pointed out, just looking at loss of employment and the fact that patients are not able to work after an ARDS diagnosis over a year, that cost is going to be reflected upon the public because they need those services and they can't pay for them.
Mm-hmm. So what are healthcare institutions doing to reduce the cost of PICS, or to help those patients recover? Are there programs out there? Probably in Europe they have better programs. I think some of the articles you had were from Europe.
Yeah, a lot of the data comes from Europe. Like I said, the post-ICU clinic, one of the main ones are a way to bridge that gap. The other part of it is increasing education for patients, family members, while they are in the hospital after their ICU stay, on what to look for, what kinds of things you can do to mitigate those risks for yourselves, and then more training and more literature for our primary care providers who are looking at these patients after they've left the hospital and are having to manage these chronic conditions thereafter.
I just want to be a peanut gallery here and comment on what's being done out there, and I guess I will be blunt maybe cynical when I say cost shifting. And what I mean by that, don't quote me on the numbers, but I saw this not within the last year or two, that in, I think it was 1976, there was 30 acute care hospitals in this country, and that is increased by 5,000%. So LTACs is what I'm saying.
LTAC, yeah.
So I see hospitals partnering with LTACs that as soon as possible to get the patient out of the hospital, they're getting them out of the hospital until an LTAC. I'm not saying that that's the wrong thing to do, but both organizations have some incentive. You know, the hospital wants them out because they can't do anything else. The LTAC wants them because they're getting money for it, but neither one of it is preventing the problem, and neither one, I don't think, decreases the cost of care.
Yeah, I certainly share your cynicism. Yeah. Dr. Douglas, I have a question for you. I noticed last week in the Wall Street Journal, Johns Hopkins publicly stated that they're reducing their updates on their famous COVID-19 dashboard, and they claim they were hampered by a reduction in state and local reporting. You seem somewhat critical of the quality of the actual information in the literature. I don't know if that's true, and if so, how do we get better information in terms of COVID-19 and some of the data you talked about?
I think, you know, the rear view is always much clearer than, I don't know, whatever that saying is. You know, it's all the reflectoscope. I don't think we're going to have a real good idea until this is all said and done. We're trying to build the airplane as we're flying it, and I know I'm a little critical of some of the research that's come out. People are doing their absolute best, but we're just learning so much so rapidly. I was talking to Dr. Kumar last night about creating these slides, and you know, he's going to be able to use his again. And it depressingly dawned on me that my talk will be outdated by Thanksgiving, and I will never be able to give it again.
Yeah.
That time I cannot get back. So I think Johns Hopkins should be prepared to update their dashboard semi-annually at least.
Yeah. And how about the variants? You talked a little bit about the variants. Do you anticipate we'll see a different forms of long COVID in the future, or it's going to be pretty much the same syndrome?
Well, I think from a definition standpoint, it's going to be the same thing. And the reason that I say that is because they have put every single symptom possible into long COVID. It's almost like when you take a new medicine and you look at the potential effects on it: constipation, diarrhea, headache, no headache. You know, so there's so much in there now that we're going to call everything long COVID.
Yeah. Any other questions from the audience at all? Yes, go ahead. Yeah.
So for a while, it seemed like we were kind of living in worlds of two COVIDs, the vaccinated and the unvaccinated. We keep hearing about how higher and higher percentages of the population have actually now had COVID. At what point do you think we can actually almost separate or not separate and just basically say, okay, it's the easiest bit of one patient population?
Well, the most recent newspaper articles that I've read is people feel like this is really in reach now. You know, herd immunity or herd vaccination is in real reach. So to answer your question, I think very soon. I don't know what to tell the patients that are still resisting vaccination other than to continue to support them and to try to convince them that this is important. You know, much like smoking, we have so much information on ill effects of smoking. You know, what do you do with people that still smoke? The only thing you can do is support them and keep giving them literature and hope that they quit. So I think your point is well taken. I am very happy with current vaccination rates across the country. It certainly helped us a lot in healthcare. I think the next iteration of studies that we see out on mortality, this whole thing about getting COVID, if you have surgery, your mortality is increased. I do expect that to go down. Maybe I'll be surprised and the mortality will stay elevated, but I think it'll come down.
Dr. Kumar, I noticed you mentioned the importance of delirium in causing PICS. What is your silver bullet for prevention of delirium intraoperatively and postoperatively? Do you have any techniques you use to reduce delirium? Because I notice your patients never have delirium.
Oh,
Mine
yeah.
all of them.
That's $1 million question. If I had the answer to that, I would be selling it right now. These are difficult questions because every case is somewhat different in what goes into it. I mean, I'm sure most of us have used Precedex as our silver bullet for most patients and dexmedetomidine as a long-standing infusion. I mean, I've seen patients on dexmedetomidine for like 2 weeks with no changes in the amount that we're giving them because we're trying to do something. The issues with delirium just come from so many different things. One of the big things being your ICU environment. If it's super loud, it's noisy, people can't get any sleep, how are we going to really help them improve? I know if I don't get a good 6 to 8 hours of sleep, I don't feel well, I don't think well, I can't function well, and a lot of our ICU patients are being woken up every hour on the dot to do something for them. And when they're not able to sleep, when they're not able to get to what otherwise would be normal, it becomes very difficult. Then on top of that, you have their critical illness to deal with, which is also difficult. So I would say what we have intraoperatively, we use as reducing our blood transfusions, being judicious in goal-directed management. We're already doing all those things, trying to address pain control intraoperatively so that they can have lower scores postoperatively, and then using that as a platform to then help them reorient better in the ICU setting and use drugs that we have like Precedex, lower sedating drugs, things like that.
Avoid surgery.
Avoid surgery. Yeah, that would be the silver bullet, I would say.
So,
Yeah, I think you touched on this briefly. One thing that I am just insistent on in the ICU is daily sedation vacation. So stopping everything, getting the patient on a spontaneous breathing trial. The data for that is so strong in getting patients extubated earlier. So I might have a patient sedated much of the day and very comfortable, but at least twice a day, I'm going to stop everything, even if the patient's kind of miserable, and get them on a CPAP trial just because I know that I can get them extubated quicker. And if I can get them extubated quicker, I can get them into a chair quicker. If I get them into a chair quicker, I can get them out of the ICU quicker, out of the hospital quicker.
Yeah, and that's an excellent point. That's one of the ABCDEF bundles. B stands for breathing trials and awakening trials being done simultaneously for those patients. So it is a part of the ICU liberation strategy, and it's an excellent point. And the faster you can get a patient extubated and out into a chair, the faster they're going to get out of the ICU.
It's one of my pet peeves to see a patient put on a spontaneous breathing trial, but they're still on like 30 or 40 mics per kg per minute of propofol, and then I hear back like, oh, the patient failed their CPAP trial. They're like on, almost anesthetic doses, and of course they're going to fail.
well, if I could just share some of my cynicism, since you shared some of your cynicism, and mine involves the
cynical.
bundles. Other than Dr. Eli at Vanderbilt, Dr. Henson's colleague, how realistic are these bundles? Especially when you have the frequent turnover in nursing, frequent turnover now in physicians. It's all you can do to write a note and get a plan of care, and you're going to tell a nurse to turn off the sedation, and you're going to walk away, and does the sedation get turned off? It just seems it's hard to do in a realistic and busy ICUs where a lot's going on. I don't know if you have a response to that at all.
Yeah, I'm thankful I get to walk away, but I'm with you. My wife is a nurse by training, and their documentation requirements are insane. This happens all the time. I'll poke my head in a room and say, "What have we done a CPAP trial yet?" And the nurse will respond, "I'll get to it, I promise." And they're over there documenting as fast as they can. So the burden is high. I get it. I don't know what to say other than the amount that we're being regulated is just soul crushing. The amount that I have to document in ICU, I feel like 90% of my time is spent with the electronic medical record and documenting. Maybe 10% of my time is with the patient. And I guess I would push back on it and say how much of it is truly necessary. I don't think we're very good at looking back and trying to figure out what has actually improved patient outcomes. If it hasn't improved care and it's costing me time, we should stop doing it.
Yeah, I agree with that as well. It's part of the issue is just increasing acuity, the amount of workload from a documentation perspective that we end up spending time on, and we don't have that same luxury to consistently be pushing on, new nurses who are not, able to keep up with doing every single part of this bundle for those patients as well. It's a difficult problem.
Any other questions from the audience? Anybody? Comments? Okay, well, if there's not any questions, that's going to be it. We'll call it quits for this morning's session. I want to please join me in thanking Dr. Douglas and Dr. Coomer for their outstanding presentations.